everybody, and welcome back to an Invisible and Invisible Illness Awareness Project. The next segment of Emerge Australia's International Symposium on ME/CFS is the clinical Q&A with Dr. Mark Donoghue and Dr. Bruce Walkup, who we already know from the first two talks, and Dr. Nicole Phillips and Dr. Don Lewis. There's some reference made to talks given yesterday. That's because this is actually, I believe, the second day of the symposium. I didn't see the first day yet, but if you guys are interested in me posting that too, then let me know in the comments and I'll make sure to get that up here for you guys if it's still online to be found. Aside from that, I didn't have too much to say about this section. What they did touch on that I really liked was if your morning pulse rate is elevated, you haven't recovered from what you've done the day before and you need to back off. That was something I found really interesting because I have been checking my vitals every day for maybe the past couple months now. And I've seen that when I'm in this malaise phase that my pulse is elevated, and I've thought, hey, maybe that's a sign of malaise, but now I have a confirmation from a doctor who specializes in this. And honestly, I would really love to have one of those watches that can constantly be measuring my vitals, just so that I know if I go into anaphylaxis or am extremely stressed. I want to know how high it gets at the highest and not just when I have the time to sit down and take it. And I want to know if my baseline is maybe lower than average so that something that is elevated for me is not elevated for somebody else. I want to really have the full picture, not just if I take it once or twice a day, when I get around to it, when I'm feeling up for it. And this just gives me one more reason to value that information. Another really interesting comment is that imagining exercise has physiological benefits and prevents deconditioning. That is amazing. That's one of those things where you can say, yeah, the mind is a very powerful thing. And unfortunately, I hear that used as more of a criticism, where people are saying the mind is so powerful, you can trick yourself into not feeling pain, so you should be able to think your way through this illness and will yourself to be better. Obviously, that is not okay, but this idea that you could be bedbound and just going through the stages of exercise in your head actually has real tangible benefits, that is amazing. There were a couple points that I took issue with in this section, and this is the first time I've actually had something critical to say. The first is, one of them said, what you can do today, you can do tomorrow. Maybe it was just an exaggeration, but in our world, that's definitely not how that works. What you can do today, you can maybe do next week or next month, but not tomorrow, because tomorrow you're going to be crashed, and you're going to be in that crash for a while. And the other point I have a problem with is shortly after that they say, always keep moving, never say just lie in bed all day. It's still problematic because when you're in that crash, you need to just lie in bed, and a lot of times it takes more than a day to recover. So where you're saying, yeah, don't push yourself beyond the limits, but just get up and do a little something every day, maybe it's not possible. Maybe you can only get up every 3 days or, every 2 weeks. Those 2 points are very much in the mind frame of someone who is healthy. And I think to apply them to a patient with ME, you have to sort of expand that time frame to not just a single day, more like whatever your time span is where you have to recover. Like when I noticed at one point I could get up and go into town and run one errand on Monday. I could get up and run one errand on Tuesday, and then on Wednesday, when I woke up before I even moved, I was already feeling that malaise. Yeah, I was able to do something 2 days in a row, but not three. And if I travel, then I need 3 days to recover, not just part of a day. So I feel like they mean well with those comments, but it just comes across slightly out of touch. And then, of course, there's always the risk that someone who is critical might see that and cling on to stuff like that as reinforcement of their own beliefs, where they're saying, oh, look, see, they said don't lie in bed all day, so you need to get up and move, and kind of push the person who needs to rest. Another little interesting tidbit was that they do touch on CFS leaks. I really don't know anything about that, but it's something that I've seen being discussed a few times lately, and I just wanted to point that out because I'm sure that will be of interest to some people. So, without further ado, here's the next segment, and I will see you guys next week.
We're going to start the clinical Q&A. So I'd like to welcome the panel. You already know Dr. Mark Donahoe. You already know Dr. Bruce Wildcope. I'd like to introduce Dr. Nicole Phillips, who is a working psychiatrist in Melbourne. And I'd like to introduce Dr. Don Lewis from the CFS Discovery Clinic. So first of all, I'm going to hand the microphone to the panel to just say a few words.
Just before we get going, and I've chatted with Mark about this, there was some comments about psychiatrists in Mark's presentation that I think we need to put on the table and bring down. So let's just globalise this. Firstly, working as a GP, I hunt out physicians, general physicians, who do not believe in chronic fatigue. They are my greatest ally. And you say, why? Because if I send the patient to this general physician and he or she does their job very well and sorts through everything and says, I can't find anything wrong, it must be psychiatric, I'm very happy I haven't missed anything. So we don't need people who just confirm CFS, we need opponents, right? Having said that, some of my best supporters have been from psychiatrists who've protected children. They said, no, this kid's not depressed, this kid's not that, this kid's got chronic fatigue. And there are some psychiatrists who move that. Now, we've got GPs who don't believe in it and who cause problems. We've got physicians who don't believe in it, who cause problems. And we've got psychiatrists who don't believe in it, cause problems. So I think we need to put that in the context of Mark's confirmational bias, because he's been hurt, or his patients have been hurt by that process. And I think you need to take that with a grain of salt.
And I'll say words for myself, and that is, psychiatry is not my problem. I'll use the line, some of my best friends are psychiatrists, and I refer to them regularly for psychiatric disease. What I didn't make clear in my talk is the removal of a person who has a clear biological illness, chronic fatigue syndrome, and when all else fails, toss them to the psychiatrist for a trial of drugs. That's not psychiatry in any true sense. That's not a diagnosis. It's the kind of what you do when you don't know what to do next. And that was the concern I have, the chronic fatigue syndrome, who are rolled into a psychiatric diagnosis, not psychiatry by itself.
As a psychiatrist?
As a psychiatrist.
Some of my best friends are.
Look, of course, Mark's correct in the sense that a lot of my colleagues have really not been good in this area at all. And I've had the opportunity over a number of meetings to try and educate them. And actually, when you get them in a group, they're quite interested to find out and want to learn. And so it's just basically lack of knowledge and, being busy with normal general psychiatry. But the issue is, it is not a straightforward condition, and there are often overlapping biopsychosocial issues. And if we ignore the psychological issues, whether they be in the background, where they were part of the precipitant along with a viral illness, whether they're perpetuating issues which, are astoundingly common when people are ill, particularly chronically, If we ignore those, then we're doing our patients a disservice. And psychiatry has an enormous role to offer, because most of us don't just give drugs to people. And this is where I think people don't actually really understand what psychiatry does. They think we just prescribe a medication, throw people out the door. I mean, every single patient of mine, whether they come for CFS or for a psychiatric problem, gets 50 minutes, whether they want it or not. And it's a holistic session. So various forms of therapy, psychotherapy is done, medication if required, and done in an appropriate, sensible way, nutrition, lifestyle, all the other things that make up a holistic treatment plan. And many of my colleagues work in a similar way. So we're not devils, and we're not necessarily saying these people have depression and not CFS, but we are well trained at teasing out what is depression, what is anxiety, what was there before, what has come on after, and treating what we can treat to alleviate suffering.
Thank you. Okay, first question. So, first question is, both GP and rheumatologist are pushing for more exercise despite typical post-exercise crashes. What can I do?
Well, this is the problem that where there is one treatment strategy that is imprinted into the way in which doctors will treat CFS, but of recent times has been shown to have, and as was mentioned yesterday, real difficulties in accepting that that exercise is essential for their management. However, there are times when there is actually a place for exercise within the person's capacity to do it, and so I describe that as their bounds of capacity, and it's important that is what is kept up, not actually trying to progressively increase your bounds of capacity, but basically to identify what can be done, and in that way there will be benefit. And eventually you may find that within yourself you may know that you have the ability to do more, and then you can do it. But by trying to do more will not work.
Yeah, the psychiatrist will speak to this as well. Obviously, I've had a number of patients through and seen pros and cons of exercise. From my personal experience, and it may not be obviously as great as these wonderful GPs sitting next to me, exercise or some degree of activity has a place in certain stages of the illness. So when I see patients who are acutely unwell, when they've just become unwell and they've got a lot of the sort of lymphadenopathy, night sweats, those type of infective type symptoms, or when they have those symptoms in a relapse, like you would with someone, let's say, who has a pneumonia or a flu, you're not going to send them out and exercise. It just doesn't make sense. But when the illness has sort of settled into this chronic phase where those symptoms have dissipated, I think that activity, as Don said, within the envelope is incredibly important, because we know that activity improves things like the microbiome. We know that that's positively responding well to activity. It's also helps with inflammation, and mood, and all the other things that we know that some degree of movement helps with. So I think that we've also got to understand there are groups of patients, and then patients differ within their illness in terms of their relapses and remissions. So different levels of activity may be required at different times, but I don't think that we should throw it out completely, because I have seen some of my patients personally who have very slowly, I'm talking over months and months and months and months, little by little by little, actually improve. So there are groups that do not, there are groups that do. Of course, we don't know how to differentiate them properly yet.
I think we're all in agreement. So point number one, graded exercise or the PACE program, which just forces an increase of things being proven to be wrong. Okay, does that mean that exercise is wrong? No. And both speakers have said exercise must occur within the energy envelope of the person. Because remember, if you push through that energy envelope, you degrade ATP to ADP, ADP to AMP, and that gets flushed out, and then you're in a corner. So you don't want to push through your energy envelope. So the question is, how do you know when you're staying in your energy envelope? What you do is you plot your morning pulse rate. So to the answer to the patient, you say to this patient, I want you to plot your morning pulse rate for 5 to 7 days, and then do the exercise that's required and look at the pulse the next morning and keep plotting the pulse. If your morning pulse rate in the morning starts to rise, you need to back off. Your body hasn't recovered. Okay, so as simple as that. Nothing wrong with exercise. We all believe exercise helps within the energy envelope. I tell my patients in bedridden, see if you can get to the next room and come back. See if you can get to the kitchen and come back. See if you can get to the post box and come back. And when they're doing that, they move up by 10 days at a time. See if you can get to the next Stobie pole or electrical pole in the street and do that for a week or two. Then get to the next pole. But they've got to monitor their morning pulse rate. If their morning pulse rate's going up, back off.
Yes, in this case, we do all agree. There is a problem, and that is currently a lot of the Social Security and NDIS demands that you fail the exercise program, the graded exercise. And so people are being pushed in order to prove they're sick to fail these programs. And so Centrelink will write back and say, have they done graded exercise and have they failed yet? Which is a pretty cruel thing to do, to say you get money as long as we crash you with exercise. I have no doubt that movement of the body, movement of the muscles, exercise, has a positive impact on almost all aspects of health. I'm lifestyle medicine, it's a critical factor. And my dividing line is a little bit different. It is, if you've done stuff that you think you can do and the next morning you've crashed and you don't recover for another day, then you've done too much the day before. Rather than being fanatical, people can get quite fanatical about watching their pulse. There's normal physiological pulse rise, and then there's a question of consequences. Did you overdo it? And one other thing I'd raise that does work is that even bedbound people, there is evidence that if you exercise in the mind, that you imagine the exercise, that you do it mentally, you get a lot of the physiological correlates of doing the exercise itself. You get not the loss of muscle mass, you get the bone mass remaining. No one that I know of has come up with a good reason why that works, but the imagining of exercise, again, doing it as a mental task, also has physiological benefits and does keep from deconditioning. Sorry, I'm running out of water again. So I think it's flawed to just say everyone does a thing. Inflammation, acute inflammation, as was said, that's not the time to be doing it. People with POTS who can't stand up, let alone exercise, don't make them exercise because they fall over and bust something. And there's obvious groupings there that you say that's not a good idea. But for the others, movement is life, and it does convince the body in reverse to get back to function.
Thank you. Second question. Is there any evidence other than stories from families such as the questioners for a genetic predisposition to contracting ME/CFS or studies into this area? So it's a question about evidence for a genetic predisposition to contracting ME/CFS. Do you want to do
Yeah, so we for the person who, please go back and look at Dr. Fayle's Dr. Fair's, P-H-A-R, Fair? Is it Fair? Dr. Fair, got him. Dr. Fair's presentation and the work where they've looked at and the question was, is it a common disease or a rare disease? It's relatively common. And he said, well, there should be a common gene problem if there's a common disease, and they've isolated some which they're doing work on. That's, I think, as far as you can say, and they've got theories for why it might work. At the stage of now proving hypotheses.
I thought I'd just share a personal story with everyone today. I developed ME-CFS 30 years ago, and I had a relapsing and remitting course over a 7-year period, and I've had a complete recovery. So the first point to make is, when Mark said there's no way out, there is a way out, even after 7 years, and I'm living proof of that. My daughter, who's 25, also has CFS, and she developed it after glandular fever several years ago, and was relatively okay for a number of years and had quite a severe relapse last year, which she's just pulling out of it. So that's just a personal anecdote about my family.
I could personally add that within my family, there has been continued expression, one way or another, and to different degrees, that CFS is present. So it's highly likely. And while I've got the microphone, and about the exercise, when people say to me, "How much do I do?" it seems to be like, how on earth am I going to know, and I can't measure exercise or whatever. What I simply say is, what you can do today, you can do tomorrow. And that we've had expressed that in similar ways here.
Okay, very short. I'll just clear out one thing. I was saying that chemical sensitivities don't recover. CFS recovery is common. Chemical sensitivities, I think, not quite so much. There are a few. The genetics, at least in my own practice, and I think Don has this, Lewis non-secretors, about 12% of the population, approximately 70% of my practice was that increased pathogen binding, the lack of non-adhesion molecules. Methylation disorders, around 25% in the general population, more than 3/4 in my own practice. DRB1, DQ2, the DQ2 and DQ8, the so-called celiac genetics, is over 68%, as opposed to 30%. So rather than there being a gene, if you line up things that are not all that common in the right order and one person gets the whole lot of them, there is a cascade of events that each one feeds on the other. So it's genetic, yeah, but it's complex. It's not mum had it, so I necessarily have it. It's that of mum and dad, the genes that I managed to put together created susceptibilities. And if you run into the right bug or the right problem, then it will break.
Thank you. So this question is from a doctor. So one doctor to the panel of doctors. As many of my patients with chronic fatigue syndrome had become fearful of exercise due to their experience of post-exertional malaise, and given the known detrimental effect of a lack of physical activity, for example, bed sores, muscle and bone loss, when and how does one assess each person with ME-CFS as being ready for the introduction of carefully paced rehab activity?
Well, I'm with Mark. I don't think you stop it. If they're in bed, they do it in their minds. And they do what they can with their arms, and then you get them from the bedroom to a wheelchair. You try and keep them going as best as you can, and we should keep doing that. I don't think we should ever take our hands off and say rest is a good option. I'm not advocating a pacing program, but I never take your hands off and say, look, just lie in bed all day.
Yes.
Thank you. So this question is from somebody who has previously been a bone marrow donor and they've now contracted ME-CFS. So they've been told that as ME-CFS is not considered to be a communicable disease, it should not rule them out as a bone marrow donor. Can they be confident that this is the case, or does current research indicate otherwise? Do you want a moment to think?
Beyond our pay grade.
You want to answer that, Ron?
No. Ron says no. He doesn't want to answer that either. Anyone want to give it?
Okay.
That's not for the psychiatrist.
Okay. The first thing, ME-CFS is not a single condition, so it's an umbrella condition. So if you start with that logic, the next thing is, could this person possibly have a communicable disease? The answer is yes. Possibly. Is it likely? No. Is it possible? Yes. Okay.
Many of my patients, anyone that kind of get better and go to the blood bank to donate, get told to go home. So I would have thought that bone marrow would be one step further down the line of no thank you.
Thank you. When would you predict an effective treatment will become available to ME/CFS patients based on the kind of research that we've been hearing about over the last 2 days?
It's my daughter's birthday today, and she's 3, and she got a unicorn. She got a unicorn necklace.
We've heard some incredible research, and it's, in one hand, so exciting to see what's happening. You know, we know what's happening now at molecular levels. On the other hand, how is that translating into what people are doing day to day? I don't think that we should just be hanging around waiting for the one drug for this condition or the one treatment. In the meantime, there are so many things that we can do to improve quality of life and, in my humble opinion, actually help the body start to heal, both from a physical perspective, a medication, nutritional perspective, a psychological perspective, a biopsychosocial perspective. So there's lots of things we can do and we can do today, and let's do them while we're waiting for further developments.
The answers are already present because of we're understanding mechanisms more, and as was said at the beginning of the introduction of this question, what is done when somebody comes and sits in front of the doctor to say, have I got CFS? There are simple steps that can be taken that can give them reassurance that yes, or if that's what one would call it, an answer anyway, that yes, that's what you have got. And hearing somebody in the profession, because unfortunately I think the medical profession could be close to being the most hated profession within CFS ranks to a degree. And to hear somebody to be able to say, yes, you have it, and to be able to say it with certainty, that actually gives them a great big step in the treatment direction. And then we each have got protocols and strategies for uncovering what is limiting this particular person, and at our level of communication and of our level of ability to act, we can provide things that does help. And so yes, we do have it, as Nicole has said, at various psychosocial and psychological levels in terms of assurance about things, and also to one's own experience that one has and has developed over the time that one has been dealing with it, to know what will help and what won't help. So yes, treatment is available now, and yes, at the higher molecular levels and genetic levels that's been talked about today and yesterday, that confirms that at deeper levels it's proceeding, but we can also do it simply as well too.
My opinion is that until we learn to divide CFS into appropriate categories and don't lump it as CFS, while it remains CFS-ME, we're still the same 22 years away that we've been for the last 22 years since the last guidelines. As we get better at this, it's not the brilliant treatments, they've all failed. Andrew Lloyd said that, we've had 22 years of plenty of trials of big hits, nothing worked. And nothing worked because we're grouping unlike people. There are post-viral, there are POTS, there are autonomic, there are methylation issues. There are so many groups that if you ask clinicians like Bruce or me, we see them. It's really easy to pick them, and no one came to ask us. They just grab everybody and call it CFS. And there are some groups of those, some of the post-viral, post-infectious ones, where there's really promising treatments and you see people get better and stay better. And there are other ones that remain still kind of families always have it, everyone in the family's always had it, that we really don't understand. But as we get better, I think subgroups of this will emerge, and probably then technically they leave the term CFS because it's and no other cause found. Now you found another cause. That's the difficulty. What's left over is what we don't understand, not what we can't treat.
Thank you. Okay, I have two last questions. So we've got 8 minutes and two last questions. So work out the
1 minute each.
work out the length of your answers. Okay. What do you think about craniocervical instability as a possible cause for ME?
I don't have enough knowledge of it. So I have been through this a bit, and we've looked at it, and we also have the whole brainstem and the sinking brain. Plenty of women that have had epidurals. You get all kinds of problems when their neck stability is poor and the brain starts to sink down in the brainstem, and then you have treatments like clots being put into the cerebrospinal fluid that fix them, literally fix them overnight. And they get up and they walk out of there, and it was another diagnosis. It was never CFS. It was a cerebrospinal fluid leak that led the brain and the blood and the pressures of the CFS to drop. But I don't have any opinion beyond that. It's just that's one of the areas where something done by a doctor who injects something into the spinal cord, sees a person get up within 12 hours. It takes a little bit of time. 12 hours, walk out. And they may fall back again, but we don't have any other information about how they go after that time. But it is impressive when it happens.
Thank you. Okay, last question. Since ours is an illness that is not always visible, how do we best inform our employers and educators when we are heading for a crash and may need time out or a reduced pace?
This is where people wish they had a sling or a missing leg, where people could say, yes, well, you have got something wrong with you. That's the first thing. The second thing is that if you can get a good supportive correspondence from your doctor, now there's a few sort of hidden variables there, but if you're able to get written support that is the case, well then your employer should pay attention to that. And also I guess it depends upon the relationship that is existing within the work circumstance, where people, the relationship may be such with them that they're able to see that there is something wrong with people, because it's written all over their face of that something is going to happen, and if they don't pay attention to it, well then hopefully they would learn next time. But I think written support that this is going to happen, it has to be the first thing.
I don't know what you guys who are here thought of the QFS presentation from Holland, which was a great presentation, but if we also think about it, Q fever is wonderful because it's highlighted, it's notifiable, and you can see a person's got it. And Q fever in Australia received a lot of attention because you've got a marker, you've had an infection, and now you're under work cover, and it's costing everybody a hell of a lot of money, and then all of a sudden they realise the burden of disease. Chronic fatigue has a far greater burden of disease, but it doesn't have those initial markers. So it is a real problem when you don't have a marker to convince people that you're ill. And I'm with Don. That's why you need to make sure you've got a good relationship with your GP. It can help if you keep your pulse rate, morning pulse rates, monitoring. You can prove that you're going up. It can help if you've got some sort of markers. I'm looking forward to chatting with Neil McGregor and others about metabolomics, because I think we'll be able to maybe have urine tests by which we can say, yeah, you're entering different stages of it. That'd be wonderful. And then we could say, look, there's a urine test. you're at this stage and you can then, this is coming out in the urine, you can now then, I've got to do this. There might be things coming, but at the moment I think you're left with a good relationship with your GP.
I totally agree, and more GPs now write really good letters because they're paying attention to what the patient is saying and stopping something happening before it happens. There's two problems. One is the demands of the workplace and then the disbelief about the illness. And that disbelief about the illness is changed a bit by doctors and levels of authority that an employer can't honestly argue with. Insurers will keep finding doctors who'll say it's all rubbish to back them, but the majority view in the medical profession now is this is a serious illness that we don't know how to treat, whereas before, if we don't know how to treat, how could it be a serious illness? So I think the good relationship with the GP, I get plenty of the times now, the GP will write to me and say, here's my letter, could you support this to manage the workplace, to get workplace changes? And the number one thing that makes a difference is if the workplace is interested in the person, cares for them and makes the changes, they do massively better than the workplaces who go to try and prove that they're not sick. So just in general, getting everyone on board, that's part of the supportive team. The employer is a part of that supportive team.
Yeah, and the workplace too can obviously be another huge source of stress, because if you've only got a few weeks that you can take leave if you're well enough to work and you use all that up, you know, there's fear of losing your job, and I think it's incredibly a stressful thing. That's all I can say.
You finished 30 seconds early.